Good morning. My name is Damien Dexeus, and I'll be presenting to you the results of the sub-analysis of two studies, the Paloma trial and the Papilobs trial. Um, this is the index of a very brief presentation. I'll try to really keep it on a correct time. Um, we all know what HPV infection is, and that it is one of the most common sexually transmitted infections, and the relationship between the high-risk HPV persistent infection and the development of cervical premalignant and malignant lesions has been well established. Spain is not different to other European countries, and we have high high incidence and prevalence of infected women with HPV. Here in the slide, there's a 30%. I'm pretty sure that it might be higher than that, but nevertheless, this is the number, the figure that I found. Um, uh, the relationship between HPV infections and high risk has been very well established. HPV infections usually occur around 20s, basically when women start being sexually active, or a little bit below that. This is the age at which acquisition of the virus is extremely common. Good news is that the majority of these infections will spontaneously clear with no further consequences. But if we're unlucky and the viral subtype is a high-risk HPV, maybe 16, 18, 31, 45, whatever, then the chance of a viral persistence is clearly higher. And the highest incidence of cervical cancer occurs in women older than 35 years. So that's clearly where we don't want to get. Basically, we should try and get rid of the infection before we reach 30s, because we know that from that point onwards, maybe the chance of um, uh, getting rid of that infection will clearly decrease. There are different factors related to the viral persistence. One of them is vaginal microbiome. Um, we know that there are a few things that we can do in terms of making a microbiome more stable, in which the predominant bacteria are lactobacilli. We know that that's good news. We know that different CSTs will play a role in terms of acquisition and persistence of HPV infections. A viral, a microbiome in which lactobacilli are the most important ones, is clearly the one that we should try and achieve. If we get very various and different microbiomes with different subtypes, then the chance of getting rid of HPV infections clearly gets low. There's something that we can't do about the HPV we acquire, and then that's pretty clear. Obviously, there's a clear way we can go, and that is vaccination, for sure. But once we've been infected with HPV, then there's not much we can do in terms of changing which subtype we had. Um, uh, there's it's been clearly seen what the relationship between hormonal status and microbiome and HPV is. We know that, for example, after delivery and postpartum, the number, the quantity of estrogens decrease very quickly. Decreasing estrogens is followed by an increasing diversity of microbiome, and we know that that's not good news. After menopause, the scenario doesn't change at all. The reduction in the number of lactobacilli leads to an increased diversity, and we know already that increased diversity is not good news. So there's a higher chance in postmenopausal women um, to acquire, not maybe to acquire, but to have persistent HPV infections, and maybe even more severe lesions. This is the gel, vaginal gel that we've been testing. It's a Coriolis-based vaginal gel. Basically, we wanted to try and test if we were able to have an impact in three different areas. One of them was creating more mature transformation zone, meaning this, that if we're able to reduce the time, the window in which the HPV can penetrate in the cervical mucosa and reach the basal layer, if we're able to have a fully epithelialized squamous columnar junction area, if we do have mature metaplasia, then we might be at a higher chance of reducing the opportunity of HPV to stay there. We've already seen that we wanted to achieve something in terms of microbiome. If we are able to rebalance this vaginal microbiota by favoring the presence of lactobacilli, then we might be able to generate a situation, a status in which HPV doesn't feel especially comfortable. And on the other hand, and that's the third thing we wanted to check and study, was if we would be able to counteract the non-inflammatory microenvironment created by HPV. So this is the clinical development plan of the company. As I said before, I participated in the Paloma trial and the Papilobs trial. I won't go over this slide, just to show you with that direction that the company has decided to take and what are the studies in process nowadays. When it came to Papilobs was an observational multi-center prospective cohort study. We didn't have a control group there. Women aged 25, vaccinated or not, were included in the study. They had to obviously present low-grade cytologic alteration with a concordant colposcopy in the presence of a low-risk or a high-risk HPV. The schedule we used in terms of treatment was the A group. Total time of the treatment was for 6 months. Like that's exactly the same as with the Paloma trial. The objective of the sub-analysis was to evaluate the efficacy of Papilocare in the repairment of low-grade cervical lesions and viral clearance in women aged 35 after 6 and 12 months of treatment. This means that once we analyzed at 6 months what the results were, should we have a positive result meaning this, if we still had a cervical lesion or HPV positive, then we would extend the treatment up to 12 months. Next slide. Here we have some of the results when it came to cervical cytological normalization with concordant colposcopy, and that was repairment of low-grade cervical lesions in the high-risk HPV group after 6 months. The results in the group below 35 years was, as you see here in the purple line, 63.9. When we looked at the above 35, we went up to a 70.1. If we did this sub-analysis in the group of more than 40 years old, we saw exactly even better results. This means that probably the efficacy of the gel didn't depend on the age of the patient. And that again is good news if we remember that the chance of a spontaneous clearance of the viral infection in women aged 30, 35, or even 40 or beyond is clearly low. When we checked at the clearance of cervical lesions in high-risk HPVs, again, when we were looking at the subgroups with high risk, remember, not the subgroup, because remember that in Papilobs, we only included high-risk viruses. The results were, again, very good, both at 6 or 12 months of treatment. And remember that depended on the result at 6 months. If we had a negative result, meaning this, if we still had lesion or virus at 6 months, we would extend the treatment up to 12 months. That is the slide with which I was talking about. Sorry about that. This is the one about HPV clearance. So good news is that regardless of age, we were achieving this more or less the same clearance of high-risk HPVs. So, and that is at 6 months. So that is good news. Doesn't matter what age the patient is, and that we will achieve the same results at 6 months. When we add the extended subgroup of 12 months, the results are still the same. It doesn't matter what age the patients are. So I think I'm running out of time already. So in conclusion, and when it came to the results of Papilobs, the interim sub-analysis, the efficacy of the gel in the repairment of low-grade cervical lesions and the clearance of high-risk HPV in women aged 40 or beyond was comparable to those below 40 years. So that's, again, good news. Clearly, we need to keep studying, getting bigger figures, more numbers, more patients in the studies to really be able to demonstrate that this gel will be useful. So there's the alarm going on. Thank you very much for your attention. I think that this was the last slide. Yes, it is. So again, thank you all. I really hope we can meet soon